Hello everyone and good afternoon. Welcome to this lecture session, which is a primer for your Decury in the problem-based learning or PBL exercise that you will be having sometime next week or so. We have spent our last few decuries in honing your skills for history taking and physical examination. Now, our target is to reach a logical diagnosis and plan out the diagnostics and therapeutics for your patients to be cured or relieved of their illness. It is important, though, to be guided by the POMR system, the problem-oriented medical record. I am certain that you are familiar with this or have been introduced to it during your lectures on physical diagnosis in medicine. Initially devised over 50 years ago by Dr. Reed for establishing standards in medical record writing, it also facilitates the thought process on how to reach a diagnosis and to implement the proper treatment, hence preventing under or over-diagnosing and under or over-treating our patients. The heart of the POMR is the SOAP, short for Subjective, Objective, Assessment, and Plan. You are certainly going to use this a lot, especially that you are now going to do ward works, hopefully in the near future, as medical clerks. I hope that got you a little expectant and excited for clerkship, although admittedly it is a lot of paperwork. To emphasize, the POMR SOAP system is involved in every phase of patient care, from creating your database, devising your problem lists, making plans, writing progress notes, and even your medical abstracts and summaries. And this is how the problem list in the SLU hospital looks like in close-up and is incorporated in every medical chart you will encounter. For our first key point of the day, remember that your assessment is only as good as your database. And remember, your P or plan is only as good as your A or assessment. So this emphasizes the very meticulous and careful process of data gathering, physical examination, and finally sitting down to figure out your diagnosis. And of course later, to figure out also what the plan is for your patient in terms of the laboratories to order and the medications to give. In the PBL Decury, please familiarize yourself with this scoring rubric and refer back to it as a checklist for your outputs. It will be 50 points in total, and the case will be given to your class coordinators and will be different per section. The first point for evaluation is the problem list. How do we write it? What is placed as the problem item or entry? Here is my tip. Given a case, you must first identify the salient points. You can have different approaches to this. Maybe underlining or highlighting the salient points will do. For others, their strategy is to make a mental or written Jamboard or data list. Whichever approach you choose, you must identify and sort which of the data is important and do they comprise a single problem, and which of these can be considered as presenting manifestations and hence the problem entry. Note also that your database is not merely a copy and paste from the case. You must begin to summarize, analyze, and interpret the information gathered. Don't forget to include the pertinent negatives. Problem entries are usually just a few words. Typically, the chief complaint, but important data are added. For the purpose of your report, during which we are not yet aware of the working impression, do not yet put the diagnosis here. Include terms that describe the uniqueness and urgency of the condition. For instance, writing tertian fever or the fever that occurs every 3 days, isn't that more suggestive of the eventual diagnosis rather than just putting fever, for which you have 100 differentials or more? Or putting in menorrhagia, low platelet count, and dengue test positive, which already clinches that this patient needs urgent care and not an outpatient treatment setting, versus if you just placed NS1 positive. Try to create just a single diagnosis, but if you really feel that these are separate problems and 2 or more illnesses account for the patient's symptoms, then make a separate problem listing for this. Furthermore, our references also suggest the following guiding principles. Is there something that rings a bell in the case as a pathognomonic sign like Koplik spots in measles or Gutron papules in juvenile dermatomyositis? Has a gold standard test for diagnosing a particular illness been done, like PCR or blood culture? They deserve a place in your problem list. Or can the signs and symptoms be combined and refer to a particular organ or system, like the combination of right upper quadrant pain and Murphy's sign, pointing to a gallbladder disease and most likely later the diagnosis of cholecystitis? Or cough, tachypnea, retractions, and crackles? The most likely diagnosis is a respiratory disorder, possibly a pneumonia. Sometimes, though, the diagnosis might not be straightforward, and it is a group of diseases that we are entertaining, as in the case of, say, bruises, heavy bleeding, and slow-to-heal wounds in blood dyscrasia, or the different spectrum of rashes in VEDs. Presenting manifestations that are in common use and the pathophysio is well understood as a standalone symptom can also be listed. You will now be able to populate your problem list like this. Arrange your list according to priority and add on the subsequent entries chronologically. Note that the date of onset, whether exact or approximate, the date recorded, which is usually at consult and admission, and the status of the identified problems must be indicated. This will make your chart and your preceptor very happy. It is also acceptable to put social or environmental problems, not just your patient's medical problems, into this list. Now, in your PBL, you will be required to provide your database. Remember our salient points list earlier on? This is now going to be arranged as S and O. As a timely reminder, your S entry is not just the HPI. It begins from the general data through the HPI and includes relevant past personal history and ROS elements. The O is easy as it is the relevant PE findings of your patient. By analyzing the S and O, your clinical diagnosis should now be 80% complete. Remember that we will be evaluating also whether your diagnosis in the PBL is complete. This is a general guide. Indicate the main diagnosis, the classification, the clinical status, the etiology if possible and applicable, and complications if there are any. For example, pediatric community-acquired pneumonia, PCAPD, probably bacterial with massive pleural effusion, right. Or acute gastroenteritis, probably rotaviral, severe dehydration, secondary. What if, say, we are still unsure of the diagnosis and cannot commit yet? Sure you can. Use the "to consider" label. As in viral exanthematous disease, to consider erythema infectiosum. Does our diagnosis always have to be this long and have all the 5 parts mentioned at the side? Not necessarily. Accepted diagnosis like this, dengue fever with warning signs, is completely acceptable. What if two disease entities are dependent on each other, that the main diagnosis cannot be set apart from the second disease based on presentation? Then you can state so, like benign febrile convulsions secondary to UTI. What if the classification of the illness is not yet definitive without the benefit of, say, histology or pathology? Then you can leave the diagnosis as it is, like in leukemia. Remember that your initial clinical diagnosis is still subject to confirmation and revision depending on further studies, so it is still okay to be unsure. Is there a proper way to write the diagnosis? Well, with that in mind, the International Statistical Classification of Diseases and Related Health Problems, or ICD for short, has been devised. You can use this as a guide. The latest version, ICD-11, has already been released this year but is not yet in wide use as its predecessor, ICD-10. You will be using these slots in the hospital. Being medical clerks and eventually interns, you must also be familiar with a diagnosis that is acceptable based on the PHIC or PhilHealth case rates that will determine the medical coverage of our patients' insurance. Just as a side note, as a case in point, 2 patients who were COVID-19 positive were admitted and treated for moderate pneumonia. Upon discharge, the doctor of patient A just wrote viral pneumonia, moderate risk, which is correct. The doctor of patient B, however, wrote moderate pneumonia secondary to COVID-19. See how the changes are very minimal, but look at the striking difference of the coverage of the 2 cases. Say the hospital bill was 100,000 pesos. Patient B will not need to pay anything, whereas patient A has to shell out 85,000 pesos out of his pocket. We could have easily helped this patient by just writing the diagnosis differently. With that being said, it's now time to unlock your stock knowledge and to remember all of the lectures you've had in the classroom, whether virtual or real, and recall all of the books that you've read to analyze your patients, physical exams, symptoms, HPI, clinical course, and laboratories. What single diagnosis will account for them? Of course, you can always open your references now. It's completely fine. We'd like to emphasize at this point, though, our preferences for your Pedia references in the PBL. First, we prefer Pedia sources rather than adult ones. We prefer local sources over international ones. We prefer you reading the CPGs, researches, and journals over Google search. You will also need to explain the pathophysiology of the disease that will explain and account all of the salient points of your patient. Recall the many flowcharts like these that you have come across as a medical student. Will it help explain how my patient with measles has pneumonia, myocarditis, and ADEM? Remember that your clinical pathologic correlation is not just lifting the textbook definition of the illness, but correlating that to your individual patient. You will also be required to cite your differentials, at least 2, and justify why you consider them. Recall that your differential is the diagnosis that presents almost similarly to your primary diagnosis, and you are not entirely sure yet if that diagnosis should be rejected. The usual tabular presentation of the rule-in, rule-out style can be used. Remember to quote your references. The plan portion of the SOAP consists of several parts. The labs you order must also be justified and customized according to the diagnosis that you have just created. Consider the ideal or gold standard test, but also know the practicality and economics of your choice. In addition of other laboratories, ask yourself, is this test really needed? How will it change the direction of the management for my patient? Can he or she do without it? The therapeutic portion of the P is divided into three as seen here. In the main or definitive treatment, write the dosing, preparation, and frequency of your medications. Practice writing them as if you were writing them in the patient's chart already. Also, these treatments must conform to the clinical impression guided by the consensus guideline treatments and again customized for the individual patient. Especially in pedia, medications are given usually based on weight. Example, milligram per kilogram per dose. Are you ready for your PBL? Before that, let us take a sample case. Please feel free to pause or rewind the video at this point to read the case. Follow these steps. We will then be able to come up with these salient points list. Again, remember that your salient points are not mere repetitions of your case protocol or written report. You must summarize, synthesize, derive relevant information, and remove the unimportant ones. While at it, we can also start to identify the presenting manifestations we would like to put in the problem list entry. Are there pathognomonic signs, or signs pointing out to a group of diseases, or organ systems? Are there missing symptoms? This student has decided to put the primary finding as the combination of respiratory symptoms and that of wasting or low weight and pallor as a second nutritional problem that can be addressed separately from the first. Next, using this database, we now formulate the A or assessment, our clinical diagnosis or impression that is bronchial asthma in acute moderate exacerbation. Question: can we add an asthma classification based on the levels of control as in this table? Answer is no. Our database does not provide us enough information on the nighttime awakenings or symptoms in a day or week or how often relievers are used. Remember our key point earlier? The assessment is only as good as your database. So the answer is no. We cannot put bronchial asthma, severe persistent, in acute moderate exacerbation like that. But if we had the data, we probably could. You've probably heard of the saying, not all that wheezes is asthma, and not all asthma wheezes. But the saying, when you hear hooves, think horses, not zebras, supersedes it in this case. There are other wheezing disorders, but asthma seems the simplest and most plausible explanation for the patient's symptoms at the moment. Remember to think of the easiest first. If all of the symptoms can be explained by a single disease entity, then why not? Again, I can't help but emphasize our diagnosis is entirely dependent on our database. Is there something that cannot be explained by the impression? Then maybe it is a different problem and must be tackled separately altogether. In the PBL exercise, you will have to justify your assessment. And a simple guide for your defense is to explain each of the elements of your written diagnosis. You may put the patient's case side by side with the textbook definition of the disease. You can quote your references here again. This exercise is by no means exhaustive, and you are still going to have your asthma lectures next semester, so we will just quote a few important points. Asthma is characterized by recurrent bronchospasms manifesting as wheezing and inflammatory changes triggered by environmental factors and viral infections that are exhibited, observed, and experienced by our patient in the case. Strong family history of asthma was also noted, further strengthening our impression. Our patient is currently in an exacerbation, and based on this criteria, he has a moderate exacerbation. Now, do a counter check. Does the known pathophysiology of asthma explain all of my patient's symptoms? If the answer is yes, refer back again to your individual patient. The asthma exacerbation diagnosis is indeed a match. Success! Next, provide your differential diagnosis. Rather than tabular, I decided to present it in an outline or bulleted list. This type of justification works too. Do you remember your lectures from respiratory disorders last week? Do you think bronchiolitis is a good differential? Finally, it is time to move on to the last part of the POMR. Don't forget our dictum, base your P from your A. In our patient presenting with an acute asthma exacerbation, the diagnostics that we want to order for our patient are very few. For now, pulse oximetry and a PEFR measurement will do. Justify in your report why you need this. Should I order a CBC? No, not needed at the moment. How about a chest x-ray or radiograph? Well, nothing in my PE suggests other respiratory complications, so I will defer it as well. How about an ABG? If my patient continues to get worse, even with the medications I gave, then I probably will. At the OPD or ER, I will nebulize my patient with the following medications. Salbutamol neb 2.5 mg per 2.5 ml nebule, 1 nebule every 20 minutes by mouthpiece via jet nebulizer for 1 hour, and reassess. I will also start oxygen inhalation and give high back rest. While this is ongoing, I will take my patient's vital signs and reassess after each stat nebulization. Are antibiotics warranted? There was nothing in my A that suggested a diagnosis of an infectious entity, so that ain't justified. Should I give ipratropium or steroid? Well, that depends after the response to the stat nebs. At the moment though, this is all that is required. While the patient is having his nebs, I can already start giving instructions for patient and parent education. I will repeat these and further emphasize them if my patient is stable enough and fit for discharge. Be specific in your report about your advice. Attach illustrations, checklists, or even handouts. Every patient encounter is an opportunity for patient education. At this point, we are not sure of the outcome. Our patient can be discharged for continuing home medications or admitted for further medical care. Your preceptor can ask scenario questions to test your knowledge on management. So, look up the consensus guidelines again for the ideal or prescribed treatment for the disease of interest and in its various stages. It is a very good resource and gets updated often based on research and experience. Consider it a best practices guideline. Usually, there are flowcharts that will help you decide on the treatment. Use this to your advantage. Lastly, a few more reminders. Remember that there is no one single and absolute correct diagnosis at the get-go. Your clinical diagnosis may change over time and after more data is collected. Your diagnosis depends on how you analyze the patient's case, how keen you are to the salient points, and your ability to put them together and make a logical diagnosis. Sure, it is necessary to get the patient's actual diagnosis, but equally important is how you arrived at that diagnosis. And with that, thank you very much for your attention and your time. Good afternoon.